Welcome to the University of California, Davis and the UC Davis Health System. My name is Fred Myers. I'm the Executive Associate Dean of the School of Medicine. And wow, what a turnout. This is pretty exciting. I see a lot of faces I recognize from our previous stem cell dialogues. Many of you know that we've had really interesting, engaging, fun evenings talking about how stem cells and regenerative medicine are changing how we approach cardiovascular disease, cancer, neurological diseases, including Huntington's disease and Parkinson's disease. It's been fascinating. Last time we heard about AIDS and HIV and some of the really cool things that the group is doing and combining gene therapy with regenerative medicine. So I leave every one of these sessions energized and admiring the work that our group does. So I'm really appreciate, and we all appreciate being able to share with you the things that we get excited about. Let me just say, none of this can happen at UC Davis without you. We really appreciate and don't take for granted the remarkable community support that we enjoy here in the greater Sacramento area and in the Central Valley. You inspire us to do better. It really means something for us to have all of you come here tonight. Many of you have supported us through your philanthropy. You've supported us through your personal stories. And I can tell you that it really helps us to work smarter, work harder, and inspires all of us. So thank you so much for everything you do for us. It does mean a lot to us. Many of you know how we approach things here at UC Davis, and particularly in stem cells and regenerative medicine. And I think it's pretty unique to Davis how we do it. First of all, we find experts in areas of significant health problems, clinical issues, heart disease, cancer. Tonight we're going to hear about pain. And we have experts in pain medicine at Davis, and you're going to hear one of them tonight, Dr. Scott Fishman, who's truly an international luminary in pain medicine. And he's going to tell you just a little bit about the problem of chronic pain in this country. We've done the same thing when we talked about cancer, AIDS, heart disease, neurological disease, and we take that expertise, and we often combine that expertise then with our researchers, and it informs the researchers how to be smarter and work better as they go back to the lab or to work on their computers. And so we know that we're developing solutions for real-world problems. And those solutions then come back to the expert, like Dr. Fishman, or you'll hear about from Dr. Kim, our neurosurgeon, about how we combine that expertise for new and exciting solutions. And so that's the second thing we do. The first thing we do is we go from the clinic to the lab. We don't go from the lab to the clinic. We go back and forth, but we start by understanding the issues that affect you individually or in the populations and communities we serve. But then we deliberately put people together who are different than each other. It's a kind of diversity of thought. And we have people look at these problems from different vantage points. And so tonight you're going to hear from Dr. Jan Nolte, who's the director of our Institute for Regenerative Cures, a professor of internal medicine, and truly an international expert in the basic biology as well as the biology of regenerative medicine to enhance the cures of illnesses that we all face together. Dr. Nolte is recognized by the National Institutes of Health, by all of the grants that she's received, and by numerous awards, with her expertise coming at it from a laboratory-based perspective. And then we'll hear from Dr. Scott Fishman, professor of anesthesiology. Now, Scott is diversity all wrapped up into one person. Oh, I'm not going to tell him about all the things. Later, I can be bribed. So Scott has training in psychiatry, anesthesiology, and internal medicine. And he's a heck of a dad with two nice kids, too. But that's part of the different story. So Scott comes from this from the viewpoint of remarkable expertise and insight into how pain develops, who's susceptible to pain, what it means to have pain, how he works with palliative care physicians, and most importantly, how some of the newer therapies are beginning to control chronic and acute pain. So Scott's pretty different than Jan. You wouldn't ordinarily think, well, I'm going to put a stem cell expert with a pain expert. And then just to make it a little more interesting, we're going to put a neurosurgeon into the mix. You know, that kind of quiet, empathetic, type B kind of guy, right? Maybe not. So Dr. Ki Kim, who's associate professor in our department of neurological surgery, and frankly, let me tell you, many of you know I'm a cancer physician. If I have a cancer patient who's having a complication in their bones, he's my go-to guy. Okay, I just call Dr. Kim because I know he's responsive, he's empathetic, and he is a technical genius. He knows exactly what he's doing when it comes to fixing people, particularly when there's a spine problem. So we're going to put together Dr. Nolte, Dr. Fishman, and Dr. Kim, and we're going to see how they look at these different problems, and we're going to now enhance our understanding of regenerative medicine through these three different perspectives. And remember what we learned, particularly when we were talking about heart disease. We're going from replacement and traditional treatments now to regeneration. We're making new blood vessels, we're making new bone marrows, and now tonight we're going to talk about making new nerve cells to alleviate chronic pain. So I think we're in for a real exciting time. Dr. Nolte is going to kick us off by giving us an update on what's going on in her Institute for Regenerative Cures, which you know is right down the street. Many of you have toured our institute, and you're all welcome to do that anytime. Funded partially by Prop 71 and partially by the University of California Davis Health System. It's a beautiful facility, cutting-edge technology, and Jan will give us an update on what her team of people are doing down there. And then she'll tell us a little bit, setting the stage, about some of the biology of stem cells. Scott's going to talk to us about pain, and then Dr. Kim's going to talk to us about some of the exciting clinical trials that are ongoing in pain medicine and relieving pain. And you need to know that that's what it's all about for us. We want to get these new treatments to you, to people in all of these areas. And so this is one example tonight about how we're translating advances in science and clinical medicine into improved cures. So with that as an introduction, I think I'll have Dr. Nolte come up to the podium, and she's going to give us a background on some of the neat things. And I think what you'll get from Dr. Nolte also is a realization that a lot of what happens here is not just in the UC Davis School of Medicine or in the health system, but all across UC Davis. Every time I hear Jan talk, it's tremendously exciting and inspiring. So, Dr. Nolte, thank you very much.
Thank you very much. It's thrilling to see so many people here. This is the first time we've actually packed this room. It's wonderful. So thank you so much for coming, and especially in the rain. Wonderful. I'm going to give an overview of our program and really what's going on very broadly, tell you a little bit about the type of stem cells that are actually being used in these two clinical trials for chronic pain that Dr. Kim will tell you about later, the mesenchymal stem cells. So let's start with talking about the program in general. We have a huge stem cell program here. We have over 150 faculty members affiliated with the program. I know this is a very busy slide, and I don't want you to be able to read all of it, but these are our 15 different teams that let's use the mouse here, 15 different teams working in stem cell therapies. And the green arrows show you the teams that actually have a stem cell clinical trial or several ongoing right now. So most of the teams have some type of stem cell therapy ongoing. And two of them, the spinal vertebra and disc repair for chronic pain, are what you're going to hear about tonight. It's incredibly exciting work. We work together in the UC Davis Institute for Regenerative Cures. This is our hub for stem cell therapies and stem cell meetings and get-togethers. It opened in March 2010. It's a very large building, 109,000 square feet. We have a lot of people working in there, over 200 scientists and physicians working together. And that's how we do these different teams for different areas. Some of you may have been at our groundbreaking ceremony shown here. This stem cell center used to be a big empty warehouse. And when I came back here to UC Davis, I grew up in the area, went to Sac State and then UC Davis, and then went away for a few years. When I came back almost exactly 5 years ago, it looked like what you see on the left, a big empty warehouse with rafters and concrete and nothing in it. And our deans had vision, I have to say, and we renovated it. We got a grant from the state funding, the Proposition 71 funding that a lot of you voted for. Thank you very much. That's what really keeps us in business. And here's just a snapshot recently showing how it's that same view right there is now a very busy laboratory with many different labs in there and teams working together in that area. We're very proud of it. This is the floor plan, what it looks like. We have, let's see, this guy working is kind of stuck. Okay. We have the Clinical Translational Science Center. They help us get to, sorry, mouse was upside down, that's the problem. They help us really with many things that allow us to get to the clinical trials, to get for what we call from the bench to the bedside, to make the science happen and get into clinical trials. We have a basic discovery lab, a very large lab that you just saw the picture of, where many scientists work side by side. And then we have this translational lab, or what we call good laboratory practice. And this is where the teams really work side by side developing these stem cell therapies. So trying to get from the bench to the bedside to develop the therapies and to then get approval from the Food and Drug Administration so that we can start a clinical trial of stem cell therapy to help our patients. These things that we're developing in this translational lab go through toxicology testing in rodents to make sure they're safe, efficacious, and then we hope to get into this wonderful GMP facility, or good manufacturing practice facility. And this is what that looks like in there. This is a clean room facility. People that work in there gown up. They have to be exquisitely clean so that they don't put any contaminants into the cells, because these cells grown up and isolated in this lab, in these clean rooms, are actually going back into our patients for some type of stem cell therapy. So that's where we are now. We're actually doing manufacturing not just for our trials at UC Davis, but for Stanford, industry, and other institutions. And that's because there's nothing like this anywhere north of Los Angeles. We are it. We're the only one. And we have this beautiful place. And we have many things ongoing for phase 1 clinical trials. And I have to show you our fearless leader of the GMP facility, Dr. Gerhard Bauer, who's here with us tonight. And he's the one that really makes all of this happen. Here, he is gowned up with one of our students in there. He also trains a lot of students, teaches them how to do this type of cellular product manufacturing for clinical trials. He also does all of this paperwork that goes into the regulatory agencies, to the Food and Drug Administration, stacks and stacks and stacks of paperwork showing that the cells are safe and effective and manufactured in the proper way that it's safe for us to do clinical trials. So thank you, Gerhard. And has been my colleague for almost 20 years. Yeah. So tonight we're going to talk about this one type of stem cell, my favorite kind. It's called mesenchymal stem cells. These are tissue-repairing adult stem cells. So we can get them either from the bone marrow, and in this case they get harvested from brave donors. And some of you may have noticed that when I talk about the harvest, I always go like that. We get it from the iliac crest in the back of the hip. A needle goes in and we get an aspiration of the bone marrow, so that's why it comes from brave donors. We can also get it from fat tissue, from adipose tissue, very rich source of this type of stem cells. So we can collect them after surgery or from liposuction material and get a lot of these stem cells. So these act as excellent repair vehicles in the body, as you'll hear about a little later tonight from Dr. Kim. We start with bone marrow or fat donated from a qualified healthy donor. We then grow them up to large numbers in this clean room or GMP facility for transplantation into the patients who need them. These are adult stem cells, so they cannot create an entire tissue. They won't make a whole kidney or a whole liver, but they repair damaged tissues. And after we transplant them into the patient, They respond to the scene of the injury, and they produce healing factors. And so we call them paramedics because they're really like a ambulance that would get to the scene of the damage and has the toolbox of the things that they need to produce and to give to that tissue to make it heal. They also are known to have a very strong safety profile in the clinical trials that have been done to date, so they're safe. This is what they look like. They're cells that grow on the bottom of a dish, little cute cells, very cute to me. I love them. They can be, what's exciting about these cells is that they can be transplanted from unrelated donors without rejection. So when you think about like a kidney transplant or a bone marrow transplant, you have to have the donor very closely typed, so tissue typed to match the recipient. Not so with these cells. They actively evade the immune system. And that's very good for us because it means that we can make a big batch of these tissue repairing cells in the good manufacturing practice facility, and then we can transplant them into many recipients who need them, and they will not be rejected. So one of the magical things about those type of cells. So let's see if the video is going to work. This is a little video that we have. If anybody's interested, I can show you where to get it online. It has been published, and it just shows the cells moving around and how much they interact with each other. And one of the things that they do is that they really move around throughout our tissues, and they check other tissues to see if they're healthy. And if they're not, they can manufacture proteins, growth factors, to help that tissue repair. And this is the type of stem cell that Dr. Kim will be talking about this evening for repair of the vertebrae and discs. So we don't just have human patients at UC Davis. We also have canine and equine patients and other companion animals. They've even treated some zebras and even elephants at the zoo, amazingly. And the use of these, this type of stem cell, the mesenchymal stem cells for each patient population, is actually in practice now at UC Davis. So it's getting to be almost routine to use this type of stem cell isolated from fat to treat dogs that have arthritis and degenerating hips, hip dysplasia, and who are in a lot of pain. Dogs that cannot jump up onto the couch anymore or into the car, older dogs. And what happens is that you can take the veterinarian and our wonderful vets out at UC Davis will take a sample of fat from the dog, isolate out the stem cells, or grow them out, expand them like we do in our good manufacturing practice facility out at our School of Veterinary Medicine. And then they return them into the dog's hips or into their spinal area, the vertebrae, or into the area where the dog's having a lot of pain. And there have been truly remarkable results. And this is getting really to be almost routine for animal patients. So we're hoping that in the future we can get to that for human patients. And that's part of what we'll hear about tonight is the early phase trials for that. So this is just showing a little picture I like to show here. Daisy, who's one of our stem cell recipients, and she's had millions of these mesenchymal stem cells as therapy, and she's very healthy and happy beagle. We also have the Center for Equine Health. They have a regenerative medicine program out at our School of Veterinary Medicine. This is Dr. Galupo, who treats the horses. And they get the horse's bone marrow or the horse's fat, isolate out this same type of stem cell, and use it for a lot of bone and tendon and athletic injuries that the horses get. Our goal here at the School of Medicine is really to treat our human patients, but we learn a lot from our animal patients. And so we learn a lot from our patients that we take back to the bench. We strive to develop better therapies. Dr. Fierro is in the back. He's working a lot on these mesenchymal stem cell therapies for bone, for non-healing wounds. Work very hard with teams, and then try to develop a type of clinical trial that's very exciting, like you're going to hear about tonight. This is a list of trials that we have ongoing and pending. I showed you kind of an overview of our teams at the beginning, but we have stem cell clinical trials ongoing for bone fractures, cardiac infarction, heart attack, peripheral vascular disease, stem cell therapy transplants for HIV. We have trachea engineering going on and larynx transplantation, bioengineering, the vertebral body fusion and disc repair that you'll hear about tonight. That's our pain team. Retinal occlusion causing blindness. We just had the paperwork approved by the FDA, so we're hoping to start this soon when we get some funding. Umbilical cord blood infusion for traumatic brain injury, and we're working on clinical trials for liver disease and for Huntington's disease. What's exciting is that with clinical trials ongoing right now, and so many of them ongoing, in the next few years, prescriptions will be written for stem cells to treat intractable diseases and injuries. So imagine that you go into the emergency room after a heart attack and get prescribed a bag of stem cells that's in the freezer. And that can actually work with this type of mesenchymal stem cell that we're talking about tonight, because they're really universal donors. So you can get those qualified cells. Any recipient can get them. And that's really where our field is going, and it's just so exciting to us. Every day I can't wait to get to work and just see what's happening with one of our teams. So I want to really thank California Institute for Regenerative Medicine. We get about 80% of our funding from this. This is from Proposition 71, or the state funding. In stem cells, we get only about 10% from the National Institutes of Health. It's a little more difficult. And when we put in grants to either of these agencies, it's about a year until the money might come back if we're funded. We get about maybe 10% of the grants that we put in. But private philanthropy allows us to stay right on the cutting edge. We can use the money immediately and put it toward the newest, most cutting edge ideas and therapies. So I want to thank everybody that's donated to us. We are really grateful. And finally, this takes teamwork. So this is the group of people who work in our translational or bench-to-bedside side of the Institute for Regenerative Cures. And I thank every one of them for everything that they do every day. And that's what I have tonight. So thank you. And with that, I'll introduce my amazing colleague, Dr. Fishman.
Thank you. Well, thank you. I hope you can all hear. I'm quite humbled to be here with this group. I want to thank Dr. Myers for his very kind introduction. As some of you may know, but many might not know, that Dr. Myers is a luminary in pain management. He's one of the international leaders in end-of-life care, dealing with quality of care for those who are at the end of life. And I think his leadership and the support that programs like mine get, being the pain management program, which is so unique at UC Davis, is really a reflection of this institution's commitment to quality of life from really birth to death. It's very, very exciting for me to now be able to work with a group like Dr. Nolte's, who frankly are peeking at the future. This is the future. And I get a little giddy just thinking about what we're seeing with stem cells. I hope the future will come fast. And I think it's with the efforts of Dr. Nolte and our group that we may see this sooner than later. So my job for you tonight is to give you some background and give you some context with which we look at pain and why stem cell therapies are going to be a paradigm shift. They're going to be a game changer in the way that we look at pain, suffering, and quality of life in America. But in trying to understand what the future holds, I think we need to step back and look a little bit at the past. And I put this up here because I wanted to just share the story with you that when I tell my colleagues that I'm a pain specialist, they often offer me their condolences. And the reason is that many in medicine can't imagine treating pain all the time. I think it's one of the really most honorable things you can do in medicine. I mean, most of us go into medicine to help people with suffering, but in medicine we've gotten very focused on curing diseases and ordering lab tests and getting images and very objective things, all of which pain is not. Pain is actually something that's extremely hard to define. And in fact, I would suggest to you that any one of you could define pain for yourselves, but not a single one of you could define pain so that even half of this group would agree with you. when you got right down to it. And that's the problem, that pain is believed by many to be a sensation, but really what it is an experience. I spent a lot of my career when I came out as fully trained as a pain specialist trying to convince my patients that I didn't think their pain was all in their head. Because thinking that it was all in their head meant that, I thought they had a mental illness and not a physical illness. And I thought that I wasn't required to take care of the physical problem when they really had a true illness, even if I couldn't diagnose it. And even if I couldn't diagnose it, I knew I could help them get better. And then I had an epiphany one day, and that was that you can't have pain without a head. Kind of simple. And what that drove home for me is that this is complicated because it relates to the whole person. You can't treat someone's pain and just treat their arm or their leg. One of the great quotes that I remember from Dr. Myers, I don't know if you remember saying this, but you once gave a lecture and you talked about how doctors today are having relationships with diseases and not with people. And that is a key fundamental problem with the way that medicine has evolved. And I want to talk a little bit about that with you today and talk about pain management and a little bit about why my colleagues offer me their condolences. One of them is that pain is so widespread and we're so poorly prepared to deal with it. Pain, according to the World Health Organization, is the #1 health problem in America. It's surprising to most. According to the Department of Health and Human Services, people with chronic pain outnumber people with diabetes, heart disease, and cancer combined. Heart disease, cancer, and diabetes combined. This is a big problem. At UC Davis and in our pain center, we do a lot of legislative and policy work, and we spent years working on a bill in Congress called the Pain Care Policy Act. And the bill was focused on getting our legislators and our healthcare regulatory institutions in America to focus on the problem of pain. And there are many different provisions. We got the bill passed in the House of Representatives twice, but each time we got to the Senate, there was one senator who blocked the bill, Senator Coburn, who actually is a physician. And there's something that they call the Coburn exception. And he takes exception to government getting involved in healthcare. And one senator, this is what I learned in my tenure doing this, one senator can block a bill. The bill was brought by Orrin Hatch. And Senator Hatch recognized that the bill wasn't going anywhere. He was one of the co-chairs of the Health Committee in the Senate with Ted Kennedy. And he got the Pain Care Policy Act basically hidden in the health care reform bill that ultimately passed. And he knew it was going to pass, but he ultimately voted against the bill. But he made sure that his Pain Care Policy Act was in there. And one of the tenets of the act was that it required Congress to mandate a full review of pain in America. And the way that that's done is through a process called the Institute of Medicine. And they took on a full review of pain in America. And what they found, then this was just reported about 5 or 6 months ago. And what they found was even astonishing to me. What they came forward with was essentially a report that stated that 116 million Americans suffer from chronic pain. 116 million Americans at any given time, at an annual direct and indirect cost of over $600 billion a year. Just staggering numbers. So we're talking about, 1/3 of Americans, 1 out of 3, some say 1 out of 2. This was actually an article that just came out about 2 weeks ago in the New England Journal of Medicine. And I just wanted, and it was written by Phil Pizzo, who chaired the Institute of Medicine committee. He's actually the dean at Stanford. And it's a really remarkable article that would be understandable by anybody if you're interested. It's only about 2 pages, but the statements in it are dramatic. And one of them is that effective pain management is a moral imperative, a professional responsibility, and the duty of people in the healing professions. To me, what's remarkable about that statement is that we have to say it, actually. You would think that that would be something that in medicine we would just know intrinsically. You know, the basis, the foundation of medicine, the philosophy of medicine is based on curing when we can, but treating suffering always. And unfortunately in medicine we have wandered from this basic covenant. And I think a good question for us to ponder is why? How did this happen? How did we get here? That we have a medical society that has such a problem of undertreated pain and such an enormous population of people who are suffering. And I think the answer is that we left that philosophy of curing when we can and treating suffering always, and we focused on curing. We focused on objective medicine. It goes back to Dr. Meyer's quote about doctors are having relationships with diseases and not people. And we forgot in medicine that it really is about the quality of life of the individual and the choices that individuals want to make. And I've got to tell you, I think 20 years ago, if I was standing before you, I would tell you that medicine was an abject failure in dealing with quality of life. We were focused on curing diseases. We were focused on measuring molecules and imaging and really the technological revelation of medicine that has led to increased lifespan, tremendous increased lifespan, increased quantity of life, but not necessarily increased quality of life. So the question is, we're all going to potentially live longer. Are we going to be happy about it? And really, it's quite a dramatic thing to think about because we've got a problem. We've got a huge population who are having pain. Many of us may be looking at that down the road or even currently. And we have a completely untrained medical community. And that is, I think, shocking and should be shocking to consumers. Pain is the most common reason a person goes to a doctor, and yet it is barely taught to medical students, nursing students, pharmacists, physical therapists, barely covered in basic training, barely covered in residencies. So why is that? And the question is, we haven't valued it. And now we're being forced to value it because we're starting to recognize that this is important, and it may be critically important for us to deal with, the healthcare cost mess that we have right now. I mean, $600 billion in financial cost, and then, the cost and suffering is immeasurable that we deal with. So this is profound. The good news is we've made enormous advances in the last 20 years. And I'm very proud to say that I work at an institution that's led the way, that really values quality of life and what we can bring to the table to help the patients that we serve. We've created an entirely new discipline within medicine that didn't exist 20 years ago, and that's my discipline. It's called pain medicine. It's an interdisciplinary area. It's made from doctors of all walks of life, so to speak, meaning that we have internists and psychiatrists and anesthesiologists and physical medicine doctors and neurologists and neurosurgeons all working together to deal with that whole person. And we expect each of us to be able to deal with each person directly with that breadth of knowledge. That is a radical change. And I think something that deservedly distinguishes us at UC Davis. So this is an emerging field. And it's really based on a paradigm shift of thought. If I asked a group of doctors 20 years ago, what is pain? They would tell you that it's a symptom. I think most people would tell you that pain is a symptom. But what happens when that symptom becomes the disease? What happens when the alarm system that is essentially there to tell you that you have been harmed or potentially harmed or you're healing, a system that is intricately necessary for survival and adaptation? You know, many of you might think it would be nice never to feel pain, but there are actually people who are born without the ability to feel pain, and they actually live miserable lives. They injure themselves all the time, and they die young. So even though we try to avoid pain, the alarm is necessary. But what happens when the alarm breaks? Just like what happens in multiple sclerosis when the nervous system is attacked. What happens in cardiac disease when the blood vessels are attacked? Well, the same thing happens with pain. When the nervous system that subserves that alarm system becomes broken, it becomes a recipe for torture because the alarm doesn't turn off anymore normally. And that's when we have to intervene, not on a symptom, but on a disease itself. And that's the paradigm shift that has occurred really in the last 15 years and mostly in the last 10 years, and I'm proud to say largely here. Now, in terms of our discussion around stem cells, what is unique about this peek at the future is that stem cells offer us a promise that we have never been able to make to you. In pain medicine, we can do so much now to help with quality of life. What the Institute of Medicine said is that we need new pain treatments, but if all we did was use the treatments we have today, we would do exponentially better than we do, and patients would do better, and we would actually pay less for health care. So I just made a list of the things we can do, and I want to discuss what the price is of the things we can do. We can deal with the mind. We've had 5,000 years of history dealing with mental aspects of pain. And I could go on and on about this, and I won't. But the mind has the power to create pain, and it actually has the power to take it away. It's very, very powerful. However, you're still not changing the underlying problem. The same is true for making the body stronger. You're still not changing the underlying problem. There are alternative therapies that will essentially deal with your mind, your body, but still don't change the underlying problem. We have conventional medicines that not only don't change the underlying problem, but have a whole host of side effects. And what I'm sorry to have to tell you is there's no medicine that doesn't potentially have side effects. So you're taking one risk and treating it with another. Usually it's a good deal. But in medicine, that's what we're doing, is we're always weighing the risks and the benefits. We're always looking at what is the potential problem of doing nothing versus this treatment that may have a side effect. And then the same is true with surgery. We can do interventions and change the structure and really help people dramatically, but the structure is then changed. And when we change the structure, you take a body that is beautifully crafted to heal itself and to function properly, and now you've made it imbalanced. So whenever we operate, there's always a possibility that we will have collateral damage from that structural change. So everything we do for pain today comes with a risk. And this is where I think we're now peaking at something that is remarkable. We have never had the opportunity that we have now. One of my favorite quotes that I like to share with my patients is, we can't cure everyone, but we can make almost everyone better. Stem cell therapy gives us the possibility that we actually can start curing people. And it's one of the few treatments that I can envision that may come without the risk. Because what it's doing is it's turning back time. It's allowing tissues to get the sense that it's 20 years, 30 years, 40 years from now and act like they're new, because somewhere in them is a program for how they should process their cells according to youth or old age. and we're going to process them now as youthful cells. This is profound. The promise that stem cells have has made me feel a possibility that I never thought was going to be possible in medicine. This is very, very exciting stuff, and I'm really thrilled to be able to work with Dr. Nolte and particularly with Dr. Kim, who you're going to hear now. The bottom line for us is that we can foresee a future where we will no longer be necessary to do the jobs we do now, which will be a better world if you don't need me to take care of your pain and Dr. Kim to operate on your spine. When we can, instead of operating on the body or doing all sorts of gymnastics to get the body to not sense the pain, that we can simply restructure the body with cells, the paramedic cells that know where to go and know what to do. So this is a very bright future, and with that, I want to thank you very much, and I'll ask Dr. Kim to come up, and he's really the smart guy in this. Thank you.
Thanks, Scott. You're going to be a very hard act to follow. Thanks a lot. Well, I'd like to thank you all again for making time and joining us this evening. So you're probably wondering, some of you, why is a neurosurgeon standing in front of you talking about a pain coming from spine? Because it's such a common problem. When you look at the whole neurosurgeon population, we actually spend about 80% of our time focused on taking care of people with spine rather than brain because it's such a common problem. So let me go ahead and talk about 2 specific stem cell clinical trials for chronic pain from spine, but I also like to kind of touch upon our clinical and research expertise. First, it may be very basic and very brief introduction, anatomy introduction, focus on disc, but let me just kind of talk about the disc because a lot of problems starts from the disc itself. Just imagine jelly donut in between 2 slices of bread, okay? So that's the disc. So the jelly portion is called the nucleus pulposus, gelatinous center that you can see. Let's see if the mouse works. Here you go. Right here in the center. And then that's surrounded by very thick, fibrous outer ring. Okay, so the outer ring over there. And then the slices of bread are the end plates, cartilage end plates. So that's the disc. Part of natural aging process is disc degeneration. So in our 30s, about 1/3 of our people have some type of disc degeneration. As we get to age 60, greater than 90% of us have some type of disc degeneration. And what happens when that happens? There's a loss of disc height, loss of fluid, so the disc gets shorter. So that's why some of you are shorter than you were when you were younger. And then also changes its color. You know, disc actually looks darker when you get an MRI of that area. So focusing on pain derived from spine, let's just talk about the low back pain first. It's very common. 30 to 60 million Americans are affected. Just focusing on healthcare dollars alone, about 80 billion per year are spent trying to get better from this problem. It's the leading cause of missed work, most common cause of job-related disability. And again, as I mentioned, it starts with the disc. So this is a very schematic view of what you can expect to see as we get older. So this is a healthy young disc. And as it go through a degenerative process, it gets a little shorter. Sometimes before it reaches that stage, annulus, the thick fibrous ring, becomes weak. And then it can lead to bulging of the disc. And sometimes disc can pop out. That's what the disc herniation is. And when that happens, the nerves are here. It can push on the nerve, and you can have pain shooting down the leg in the lower back areas. That's sciatica. Sometimes we bypass this and then go later on to very worn-out disc where the spur, bone spur osteophytes form. And sometimes when the osteophytes right here where the nerves are, it can pinch the nerve and you can have the same problem. Neck pain is also very common. About 2/3 of us are affected during our lifetime. Just like back pain, variety of sources. In the neck, we actually, as a neurosurgeon, take it more seriously because there's a spinal cord that you have to deal with. So this is an example of MRI of a patient that I operated very recently who came in wheelchair. So not only pain and numbness, yet we will see with the problem in the lower back area, but because of the spinal cord has all that nerves that are controlling your arms and legs, this poor gentleman had difficulty with walking because of weakness, and he also had a bladder issue. So more serious problem and also very common problem. Just in neck alone, about 900,000 spine surgeries are performed per year. So because this is such a common problem, in 2003, we established multidisciplinary comprehensive spine center. All the specialties are covered here, including Dr. Fishman's group. We are constantly talking to each other about what is the best way to take care of patients with spinal disorder. We were recognized by Blue Cross Blue Shield to be the center of excellence. And that picture that I just showed is a very small team. We have a huge team, and that's a very small team of healthcare workers that are helping us deal with so many patients that come through our door. We're also level 1 trauma center, UC Davis Medical Center. So there's always a neurosurgeon or orthopedic spine surgeon standing by if someone needs emergent or urgent surgery, and our expertise were recognized by our peers. But just taking care of it is not enough for us, because we really want to know, because not all the patients that we treat are straightforward. Sometimes we wonder whether we're actually helping the patient by certain procedures that we perform. So it's very important that we prospectively follow our patients out to at least 2-3 years to see what we're doing actually make a difference. So that's the outcomes research that we're doing. And we also have a very, very busy clinical trials program. We have about 11 active clinical trials right now, and it covers a variety of subjects. And this is just one example of a patient that received artificial prosthetic disc for a neck problem about 5 years ago, and he was very, very happy about the fact that he did so well afterwards, and he was also very happy because this was not available to anyone else, and it's still not available. It's still not approved by FDA. It's just going through the process. So what I want to do tonight is talk about stem cells for chronic pain, but without our clinical coordinators and our staff, this would not be possible. So stem cells for spine, mesenchymal stem cells, Dr. Norta talked about, undifferentiated cells that possess the ability to make bones and reverse disc degeneration. So you have a mesenchymal stem cells that makes bone, and that makes bone and then cartilage. And when you put it in the disc, something amazing happens, which I'm going to talk about later on. So this is again from healthy adult donor bone marrow that's donated, and this is grown in cell culture, GMP laboratory, expanded and concentrated, and cryopreserved, so it's in a frozen state. Much we do as a neurosurgeons and orthopedic spine surgeon when we do surgery is to accomplish these two goals. One is to take the pressure off the spinal cord and nerves, hoping that will help with the pain and restore some of the lost function, and also quite often immobilize or fuse the spine to prevent future problems. Over 350,000 fusion surgeries were performed in 2005, and that number is even higher now. And again, this is quite often primarily to treat pain. So we can use a cadaver bone to facilitate bony fusion, but the failure rate is very high. Only about 35% 35% failure rate, even in the cervical spine surgery, where it's very easy as opposed to low back surgery to achieve fusion. So there is definitely a good alternative. Synthetic material, some proteins been tried, they all have some problem. So what is the best source right now? It's actually our own hip bone. So just like taking the bone marrow aspiration, but much bigger incision during surgery, we would make an incision over here, just like here, and we will remove the bone from the iliac crest. Because it has three properties that are necessary: osteoconductive property, which is a scaffold structure that allows for vascular and cellular migration, and also osteogenic. So Dr. Nolte mentioned the bone marrow biopsy to get the stem cells. So there is a stem cell in there that can produce new bone, and then there's an osteoinductive signal that stimulate progenitor cells to differentiate and make bone. But what is the problem with that? It's very painful. Sometimes you have infection, and sometimes patients, even after their neck or back problem is taken care of, they complain about hip pain. So again, that's really not a good source, way of achieving solid bone infusion. So this is industry-sponsored study. So animal study was done to see if the stem cell, there's a role for stem cells in achieving or facilitating fusion. Sheep is very similar in terms of disc morphology to humans, so that was chosen, and surgery was performed, and 3 blinded observers looked at 24 sheep that were separated out into 3 groups. The group that received the mesenchymal stem cells had a highest fusion rate, 75%, as opposed to the other groups. So it seems to work at least in this particular animal. And then some brave volunteers volunteered to have the stem cell injected to their spine when they were having the surgery. So on the left is a neck surgery, on the right is back surgery. In the green arrow is where the stem cells were injected, utilized, and then the right side here is where patient's own hip bone was utilized. So you can see that there's more robust fusion that's taking place. So this white area is bone that you're looking, and no adverse events were noted. So that's the reason why now we're doing the multi-center, prospective, randomized, single-blinded control study to see whether this works in larger population. This is industry sponsored, so this is a university industry kind of collaboration to evaluate the safety and efficacy of allogenic mesenchymal stem cells in achieving solid bony fusion for spine surgery. And the stem cell comes frozen, so we take that out and thaw it and inject this. So we're part of this less than 10 centers nationwide that is currently enrolling patients. But what I am more excited about is what's going on with the disc. So going back to what I started out with, so on the left, you see a schematic picture of a syringe, and this is also sheep, was injected with chondroitinase ABC. So this is an enzyme. Because we can't wait for natural degenerative process to take place, we got to kind of accelerate that. So with this enzyme, you can make what may take decades for degeneration to occur within 3 months. Okay, so this is before, and right after the injection, see what happens over here. It's darker, degenerated, and this is control up here. So it's very light, normal-looking disc. This level was injected with mesenchymal stem cells and hyaluronic acid. So HA, I'm going to say, I have a hard time pronouncing that, is a carrier. So you can't just inject stem cell in there because it may just disappear. It may not stay where you want it. So HA is a carrier that would get absorbed over a period of time. And then just to make sure the carrier itself is not causing what we see in terms of benefit or even possible adverse effect, it was injected along without the stem cells. And let's see what happens. So again, upper 2 is normal, and this is after that degenerative disc was injected with mesenchymal stem cells and carrier. Look at the difference. There is actually no difference that I can see on the MRI. Whereas if you see the no treatment disc, see how dark that is and collapsed, and this is just carrier alone. So some of you are probably thinking, I wish I could have that injected in my disc. But yeah, it's pretty truly amazing, the difference that you see there. And when you actually sacrifice the sheep and take a look at the disc and see what actually happened, this is, again, non-injected control disc, and this is the enzyme that I talked about. See how you see the degenerative changes. And then this is with stem cell with the carrier. So when you compared above and below, not much difference. And this is enzyme with the carrier, without the stem cells, and you can see the degenerative changes. So not only what you can see visually, but also the height of the disc is restored with the mesenchymal stem cells. So this is under microscope, so you can see healthy disc restored with the stem cell, whereas without the stem cell, you see quite a bit of degeneration. Again, this is healthy disc, restoration of height, and also the architecture of the disc. And this is without the stem cells. So this is kind of busy study, but we are enrolling patients. This is also prospective, but double blind. So single blind means that patients who are getting the treatment does not know what type of treatment he or she is getting. Double blind is not only the patients, but the person evaluating the patient does not know what kind of treatment. So that's to reduce the bias of the study. So you get randomized, and this can be issue for a lot of my patients. And I have a patient that qualified for this study, but she is in so much pain. She's been suffering from this pain for over a year, and she says she doesn't think she can wait to get this treatment, because she, first of all, does not know that whether she's going to get a placebo, just saline or carrier, or she will be fortunate enough to end up with the stem cell. So she's choosing to have surgery because she's been suffering, and she says she just can't wait anymore. So you heard some quotes. I hear my wife often tell my kids, and I found out that it's actually a quote from a less illustrious luminary, Yogi Bear. I think my wife watched a lot of cartoons. I know for a fact that she watched a lot of cartoons when she was growing up. She would tell our kids, you got to be smarter than an average bear. And we do think at UC Davis we are smarter than the average bear, other institutions. So we were asked to write an editorial, which was published last month, just in terms of how better we can use stem cell to benefit the patients. So what will you see in the near future? You're going to see definitely disc regeneration, make the disc younger, turning back the clock. That will translate into much less spine surgery. We will still have work to do as a neurosurgeon, but I would like to see less spine surgery being performed. UC Davis will maintain its leadership in research and patient care. And under Dr. Norta's leadership, I think we're doing an excellent job in terms of applying the stem cell technology in smart fashion. If you have any questions about the study itself or the Spine Center, we have a Spine Center a practice manager back there, Megan, with some information, and then Martha Robinson, right there with some information regarding the clinical trials. She's our clinical research supervisor. Thank you very much for your attention.
Pretty exciting evening. Maybe we can get our three speakers to come up and sit here and take a few questions from the audience. And I think we've got some microphones, some handheld microphones, and our able people are going to pass those around. For those of you, if you just raise your hand, we'll try and get a microphone to you for a few questions. Okay, so question, down here, Mr. Casey's going to jog over here. He's the fit guy in the group.
This would be a question.
You're good.
So, it's a question to all three of you. In all of these particular approaches, to what degree is the age of the patient going to entitle them or reject them? In other words, if somebody's 40 or if somebody's 95, There's got to be some rationing in this, and also probably some efficacy problems in a very old person. Is
So-
that true, or
Yeah.
would it apply to everybody?
As far as the stem cells, we get them from young, healthy donors, so that's part of the qualification. So the stem cells are young, but the
Yeah.
recipient can have.
Yeah, let me have a crack at that question. So for the clinical trials, because we want to see whether this, we're talking about the disc regeneration study, works for patients who have disc degeneration, we are basically limiting those patients who have moderate disc degeneration, because we're concerned that if disc has degenerated too severely, stem cell may not be as effective and we may not see the benefit. So we have selected patients who are 18 to 75 who have moderate disc degeneration, and hope that we will get the data that will allow us to say, is this something that can also work for severely degenerated disc, or is it only effective for moderate degeneration?
Interesting question. When I started in oncology, stem cell transplants as a bone marrow transplant for certain leukemias was limited to people less than age 30, and over just a relatively short period of time, that age limit is now well up into the 60s. So as technology progresses, and as you point out, as clinical trials are developed age appropriate and looking at side effects, you can really push the envelope, and we do try to develop therapies that are appropriate and inclusive for people, but it's a sophisticated question you ask, because that's really part of clinical research.
Thank you.
If could I just comment, because number one, you asked for all of us, and number two, I think you asked a very specific question, but then a very broad question, which I think is profound. And I think many of us look at this problem as we're growing older and our tissues are simply wearing out. And while that may be true, I think there's something even more profound at play, which is that there's an intelligence that our cells have that we're just starting to tap into. And it may not just be that our cells are wearing out, but the cells have a clock, and they're programmed to stop working. And that, I think, is what we're tapping into, is retiming the cells and resetting that clock, which is something, again, we've really never been able to get at, and that window is now opening.
Thank you.
There and then down here next, yeah.
Hello, this is to any one of you that can answer it. So it seems like you guys are currently in the research phase, and it shows that the clinical trials are pretty promising. It appears that the future with this type of therapy seems bright, but you guys don't know when it'll be ready or available to have doctors be prescribing stem cells. But in TV shows and journals, you always read that there are certain clinics around the nation, around the world, that you could privately pay for and get stem cell treatment for osteoarthritis in your knee pain, and some of these shows I'm sure everybody's seen, like The Doctors and stuff like that, or how are those different than what we are doing here at UC Davis?
Please.
May I? So that's an excellent question. I'm so glad you asked that. You're asking about the topic of stem cell tourism, where people go out of the United States because the therapies are not approved by our FDA, who makes sure that we do things safely and effectively. A lot of those clinics are now being shut down because they've actually hurt people. Not all of them, some may be doing good things, but they're completely unregulated, so you don't know what you're going to get. There was an expose on one of them on 60 Minutes recently. I don't know how many people saw that. It was actually pretty amazing to see what some people will do for money and take advantage of people who are desperate by selling, what they call stem cells, and it might just be some dirty saline or something. So you just really have to think about the clinic, think about the people that are running it. Do they have a history of scientific publications? Are they really doctors? Are they just somebody pretending to be a doctor? And really research it. What we're doing here is anything that we do has approval by the Food and Drug Administration, and that's what's needed in the United States to do these clinical trials.
So in the United States, you need to be part of a clinical trial. Otherwise, it has to be until it's FDA approved and readily available for everybody.
Yeah, so it's interesting. I forgot to add this slide. So there's clinical trials are phase 1, phase 2, and phase 3. Phase 3 are big multi-center trials. These, this type of mesenchymal stem cells has already been through phase 3 trials for some indications, not for this one. For this one, they're in the early phase. And so when I say that in the near future, the stem cells may be prescribed for heart attack, that's because the phase 3 trials have already been done. So for different diseases, they're nearing FDA approval as a drug where they can be prescribed, and that should be in the near future.
Oh, okay.
Great talk, by the way. I've got a testing.
Yeah.
One of your MRIs looked just like mine. I had a cervical discectomy about 7 months ago. I'm curious, forget the disc, is there anything in the works for damage to the myelin, myelopathy? And you mentioned your patient in the wheelchair has trouble walking. I can relate to that, et cetera.
Yeah, he has a happy ending. He's actually now walking now. He's on our rehab service. He had made a very nice and rapid recovery. And the reason for that is he had direct compression of the spinal cord, and spinal cord doesn't like that kind of pressure. So the surgery was primarily to take that pressure off. So if you have still a pressure on the spinal cord, surgery may be the only option. There isn't medication that's going to relieve that pressure, or stem cells cannot do that, at least not yet.
Well, I had the surgery, so I'm just curious, will the myelin come back on its own, or is there anything that you're contemplating?
It really depends on the degree of damage that's already been done. So there is a certain amount of repair that the spinal cord does.
On its own, there's no stem cell therapy or anything. Sorry.
We'll have to put that, the demyelinating diseases may have to be the next topic for stem cell dialogues, because you're right, the covering of the nerves, the myelin, the sheath is a different issue, and like multiple sclerosis and other demyelinating diseases, we have a group of investigators very interested in that, particularly our pediatric regenerative medicine group. So stay tuned for future things in myelination. Oh. Sorry. Oh, okay.
So question in regards to autoimmune diseases, various autoimmune diseases and the pain associated with it. Has stem cell therapy been looked at for various autoimmune diseases?
There are actually bone marrow transplants going on for some types of autoimmune diseases where you can actually reset your immune system. So that's, again, a different team. But yes, there are teams working on that.
And then there's been some work in arthritis and again, regenerating the joints that are destroyed by the autoimmune system. So it would be a two-step approach where you suppress the autoimmune response and then you regenerate the joints that have been injured. But again, these are small trials and we're learning very, very quickly, but it's a bright future, but it's not readily available to the average person yet.
We're over here now on this side of the room. Yes.
Yeah, I've been in the UC Davis pain clinic off and on for about 5 years. I've had a medial branch block. I have had probably a dozen SI injections. They don't want to give me any more of those because of the amount of cortisone. Is this something that down the line I might be able to use instead of the cortisone?
So absolutely. So cortisone would be one of those treatments that I talked about. That is you're trading one risk for another. So a patient who's receiving cortisone, you'd have to ask the question, is it better to take the risk of the cortisone than the risk of ongoing pain? And we often take that risk because it's a small risk, but not a trivial one. So we're looking for better treatments. And it's interesting you mentioned the sacroiliac joint, which is a very common cause of very, very low back pain, really pain that borders the low back and the buttock. And we have novel treatments. I don't know when the last time you've been in, but maybe we could talk afterwards. We have a couple of new treatments, and one of the things we're doing is actually, we now know where the nerves are that innervate the joint, and we can actually melt those nerves. We're leading a national symposium on this subject this month at the national pain meetings on advancing novel treatments for the sacroiliac joint. Other things that we're doing is actually looking at supplements that we can put in the joint that actually give the joint buffer. Clearly, the SI joint or the sacroiliac joint is one of those interesting areas because it's a joint that actually looks like a joint until we're about 30, and then it fuses. So for most of us, that joint is fused. It's no longer a joint. And stem cells hold the promise of maybe turning that clock back to a joint that then can age properly with proper movement or optimal development. So, I think the future is bright, but even today, there are things that we can do for the sacroiliac joint that you may not have heard about.
And then there's a surgical option. He mentioned about fusion. Some patients...
we'll keep you away from him.
Down boy.
Some patients have a abnormal motion causing sacroiliitis, and in those cases, fusion sometimes is an option.
Right.
But avoid surgery if you can.
She'll come down and get you there.
You next.
For all three doctors, when you talk about the small size of the trials, how many people are you talking about? 10, 30, 200?
A fusion study that I talked about, so I talked about two ongoing trials. The numbers are smaller. It's 24, is that right, Martha? And for the disc regeneration study, I believe we're talking about 100. Is that 100? Okay, good. I was correct, so great.
Let's just,
This is to Dr. Fishman. In your writings, you indicated that you were familiar with legitimate pain care physicians that have lost their license prescribing medications. And I'm wondering today, of course you wrote that a few years ago, but I'm wondering today, are you still running into this sort of a resistance from the bureaucracy?
Again, a profound question. We have a public health crisis of undertreated pain in America, but we also have a very serious public health problem of prescription drug abuse. And the two problems are colliding. When you take those two enormous public health problems and you take a prescribing workforce, the doctors in America who are uneducated about assessing pain, treating it, and particularly on how to use controlled substances, we have a problem. And so we definitely have a problem of overusing some of the drugs that are actually essential drugs. These drugs that are called opioids or morphine-type drugs are probably the most potent, reliable drugs we have. They're good for some people, they're not good for others. And for some, they can be very, very bad. So we have to learn how to use these tools safely, and we're just catching up, frankly. It's embarrassing to say. We're catching up. And in medicine, as I said, it's all about risk and benefit. We deal with all sorts of very risky treatments. And I'll give you one example. When anesthesia was invented, anesthesia is essentially the process by which we bring somebody close to death so that we can operate on them to help them, and then we bring them back. It was widely written that this treatment was way too risky and we should abandon it. Now, if we had abandoned anesthesia, much of the progress we've seen in modern medicine would not have occurred. So every day we deal in medicine with very risky treatments, but we're very good at managing the risk. I can't say the same about pain management yet in most places. we're seeing these pill mills pop up all over the country. If any of you are interested, there's a documentary called the OxyContin Express, which is really, it's the current TV, Al Gore's TV network, where the reporters who actually were the two women who were held captive in Korea that Clinton rescued, it's actually their program. And what it shows is that these pill mills are opening in South Florida, and the OxyContin Express is actually a plane ride that addicts take from West Virginia down to South Florida to basically get pills to sell or get high. So it's really taking us in two different directions at once, where we have to deal with undertreated pain, but most of our prescribers aren't trained. So there are prescribers out there that are overprescribing. Some of them are doing them knowingly, and they're criminals. But many of them are simply trying to help their patients and probably practicing what we would all agree is not proper medicine, but they're still trying to help their patients the best they can. And I would argue that those doctors aren't criminals, but those doctors need education, and some of them need to stop prescribing. But we have this fuzzy gray line now that we're dealing with in society, and it's starting to frighten doctors. That we're seeing media attacks on anybody who supports any use of these drugs at any level, and that is really a dangerous polemic that is going to send a message to those of us who are trying to deal with the problem of undertreated pain in America, and may produce resistance, and we won't get to our solutions fast enough. So absolutely, there are cases like that out there. There are doctors who are clearly are criminals, who are selling drugs for all kinds of reasons, and none of them have to do with their patient's best interest. And then there are doctors who are practicing beneath the standard of care, but they really do have their patient's best interest at heart, and they need to be dealt with as well, but not as criminals. Does that answer your question? Thank you.
One more question, two more, maybe two more. Go ahead, Charlotte.
Hi, I just had a question. Where do you typically get your stem cells? Do you find it more advantageous to be autologous stem cells, or from, like Dr. Nolta said, from a young donor?
For most of these trials that are being tested, they're what we call allogeneic. So they're from one normal qualified donor or several normal qualified donors. And that way we can make a large batch of them in the Good Manufacturing Practice facility, qualify that batch so that it meets the standards set forth by the Food and Drug Administration that they would put on any drug or anything that would be administered to a human. There are different trials ongoing where the patient would use their own fat-derived or bone marrow-derived stem cells, but this one is qualified donors.
Right. And that donor has gone through like all kinds of tests you can imagine.
Yeah.
And
rigorous,
like,
yes.
Yeah, tons of blood drawn and tests for all kinds of possible stuff. So
viruses, mutations.
Very healthy donor, still alive.
Yeah, young.
One more, we're going to have the doctors will hang around for questions. Maybe one more question for the group, and then we'll have you come up and get your questions out. Go ahead.
Thank you. This question is for Dr. Fishman, and I asked this privately, and he said it'd be a great question to ask in the audience here. Does inflammation have anything to do with chronic pain?
So
inflammation.
Yes. And the bottom line is that inflammation is a system that is not unlike pain. It's an alarm system and a healing system that is necessary. You wouldn't want to live without the ability to have inflammation, yet you don't want inflammation. It's an ironic thing. And when that system goes awry, you can have damage. So when the system does its job, the inflammatory system does its job, it needs to turn off. And when it doesn't turn off, that's when inflammation goes from a helper to a harmer. And you actually start injuring your tissues, like in arthritis. Arthritis is really a chronic form of acute pain, meaning the pain system is actually working appropriately, but the inflammation isn't turning off normally, and it's triggering the alarm constantly. So inflammation is a major source of chronic pain, and one that actually we're probably one of the top ones that we're best at treating. And I'd be happy to tell you more about that after, since the hour's
I see
late.
lots of other hands up. Usually when I teach medical students about this time, the hall is empty. Maybe what we'll do is ask our experts to stay for a while afterwards and answer your questions up here at the front, because it's getting close to my bedtime. I will say this, you are a remarkable audience. You're so interactive and so inquisitive. I very much appreciate this type of, if you will, adult learning. As I started my comments, this type of support is so crucial to us. Your enthusiasm, your supportive nature toward us is very, very important. Many of you have also supported us with your kind and generous philanthropy. The School of Medicine has 2% of our budget comes from the state of California. So that means 98% of what we do and 100% of what you heard about tonight comes from grants and philanthropy and a lot of darn hard work by these people. So very appreciative of that type of support you've given us, and we hope your philanthropy is well rewarded tonight by this talk, and that you'll continue to invest in this type of work. So we'll hang around for a while. Thank you so much, and we hope to see you again for the next dialogue.